Hello everyone, welcome back to the channel. Today's lecture focuses on Ewing sarcoma, a member of the Ewing family of tumors. We will explore its historical evolution, clinical features, pathology, immunohistochemical profile, molecular genetics, and prognostic indicators, all from an advanced pathology perspective. The history of Ewing sarcoma is marked by evolving concepts about its origin. In 1918, Stout reported a peripheral nerve round cell tumor with rosettes. Ewing, in 1921, described a round cell neoplasm of bone and suggested an endothelial origin. Only in 1970s did Angerwall and Enzinger identify extraskeletal Ewing sarcoma, and around the same time, peanut and Eskin tumor were also described. With the advent of immunohistochemistry and cytogenetics, these tumors were shown to share the same molecular hallmark, and today all are considered part of the Ewing sarcoma spectrum. The unifying characteristic of this tumor spectrum is the presence of chromosomal translocations involving the EWSR1 gene, and the most commonly involved is translocation between chromosome 11 and 22. This molecular link confirms their close histogenetic relationship. Ewing sarcoma predominantly affects adolescents and young adults, with most of the patients having a median range of 15 years. There is a slight male bias, and it often arises in deep soft tissues of the extremities, typically presenting as a rapidly enlarging mass measuring from 5 to 10 centimeters. Only 1 to 2% of the cases are seen in the gnathic or craniofacial bones. Pain may or may not be present, and advanced imaging techniques are essential for staging and treatment planning. Grossly, the tumor is multilobulated, soft and friable with a grey-yellow cut surface. Extensive areas of necrosis and hemorrhage are typical, though calcifications is characteristically absent. Histologically, classic Ewing sarcoma shows a lobular pattern of remarkably uniform small round cells. They possess round nuclei with fine chromatin and scanty cytoplasm, often containing glycogen which may indent the nucleus. Although the tumor is well vascularized, vessels may be obscured by the tumor cells. Sometimes pseudovascular or pseudoalveolar patterns can mimic other sarcomas, but these represent the degenerative changes. A subset of cases display atypical morphology. Large cell Ewing sarcoma shows nuclear enlargement and irregular contours. The adamantinoma-like variant is particularly challenging, showing nests, desmoplasia, and keratin, as well as P40 positivity. Approximately 15% of the cases show peanut-like differentiation with Homer-Wright rosettes and rarely Flexner-Winter-Steiner rosettes also. Occasional tumors show advanced neural differentiation also. IHC remains crucial for diagnosing Ewing sarcoma. CD99 remains the most sensitive marker, though its specificity is limited, as many other round cell tumors may show CD99 membranous staining. NKX2.2 has emerged as a powerful nuclear marker linked to the EWSR1 and FLI1 activity. FLI1 staining is also frequently positive but not specific. So out of all these, NKX2.2 is the one which has the specificity as well as good sensitivity. About 1/4 of the cases show keratin positivity, typically the lower molecular weight. Adamantinoma like Ewing sarcoma shows diffuse keratin and P40 positivity. And rarely, Ewing sarcoma may express desmin also, but it lacks the myod1 and myogenin, which differentiates it from the rhabdomyosarcoma. On a molecular level, Ewing sarcoma is defined by EWSR1 and ETS gene fusions. The most common is the EWSR1 gene fusion, accounting for 85% of the cases. And after this, the next most common fusion is between the EWSR1 and ERG. And many other rare fusions are also seen. Molecular confirmation using FISH or RT-PCR is essential, especially in morphologically unusual cases. Secondary cytogenetic changes such as trisomy 8 and trisomy 12 may also occur, but their diagnostic value is low. Alterations in TP53 and P16P40 are detected in a subset of tumors and correlate with aggressive clinical behavior and resistance to the therapy. Historically, the prognosis for Ewing sarcoma was very poor. Today, approximately 75% of the patients with localized disease can achieve cure through multimodal therapy including chemoradiotherapy and surgery. However, those presenting with the metastatic disease still experience poor outcomes, with lungs and bones being the most common metastatic site. Treatment typically begins with neoadjuvant chemotherapy, followed by surgery when possible and radiotherapy as needed. Research into the targeted therapy is ongoing, focusing on pathways activated by EWSR1 and ETS fusion genes, receptor tyrosine kinases, and apoptotic pathways. Key prognostic indicators include the presence of metastasis at the diagnosis, larger tumor size, and central axis location. Extensive necrosis and poor initial response to chemotherapy also indicate worse prognosis. Some studies suggest that type 1 EWSR1 FLY1 gene fusion correlates with better outcomes, though this is not universally confirmed. In addition to classical Ewing sarcoma, there are other important Ewing-like tumors that lack the EWSR1 rearrangements. The most common significant among is the CIC rearranged sarcoma, which accounts for nearly 60 to 70% of all Ewing-like tumors. These tumors tend to behave more aggressively. Another subgroup is BCOR rearranged sarcoma, representing about 10% of Ewing-like lesions. These were identified through RNA sequencing studies and show distinct clinical, morphological, and molecular features. Although they mimic Ewing sarcoma microscopically, their molecular signatures clearly separate them into unique diagnostic entities. Before concluding, I would like to mention that I have published a detailed case report on Ewing sarcoma, which was completed during my postgraduate period. This work was carried out under the valuable guidance of my guide, with continuous support from other departmental staff and my batchmates. The link to the case report is provided in the description section. Please feel free to check it out for the deeper clinical insight. Thank you for watching, and do like, share and subscribe for more oral pathology videos.